Hello, welcome to Birthing from Within's parent member call on preparing for induction. My name is Christine Desposito. I am a birth and postpartum doula, a childbirth educator, and the director of programs at Birthing from Within. I'm so glad to be here today to offer this informative and heart-centered class. This is part of our parent membership, which I will talk just a little bit more about at the very end of our call today. So you may want to have a journal or a piece of paper so that you can take notes if you'd like as you're following along. I'm going to go through the slides here and also just narrate as I go to offer some of the things to consider if you are preparing for an induction, or even if you're not preparing for an induction, but want to learn a little bit about what some of the things are to know if this should become part of your birth. So, one of the first things is just why talk about an induction if you aren't actually planning one? Why would you want to learn about these things? And sometimes it feels counterintuitive if you are not planning to have interventions to talk about them. And birth is the unknown. There are a wide variety of possibilities that can occur, and learning about those things for the very first time in the moment, if something were to come up, isn't always the best time. So when you take some time to, you don't need to know everything, but just having some of the main factors and also some of the ideas that would help you to move through it, to cope, to stay centered or grounded, should this be something that arises. It is very normal for parents to have concerns and worries and fears as they are planning for birth, even when they aren't planning for an intervention. Just the unknown, again, of birth itself can create worry, anxiety, and fear for parents. And I've been doing this work working with parents for over 20 years. And one of the things that I have learned is that it can be really helpful to just take a little bit of time to think about, again, just a few things that might be important to know and a few ideas for how to get through it. That often can actually alleviate worry and concern. So thank you for being here. And this is important information, and we're so happy to share it with you. So this slide obviously is just speaking to what I was just sharing. And we're just going to move on to the next one here. Some of the common reasons for an induction. There are both medical and preliminary inductions. So this speaks to a situation where somebody has a medical condition, something going on that is then suggested to have an induction because that is determined to be safer for the baby to come out sooner rather than to continue in utero. Preliminary is when they are suggesting an induction because there is a potential for a medical condition to arise. And the suggestion in some of those situations is to go ahead and have an induction to avoid a medical condition arising. And then there is elective inductions, and that is for non-medical reasons. So medical and preliminary common reasons for induction: post-term pregnancy, which is beyond 40 weeks, premature rupture of membranes. So if somebody's bag of waters ruptures and they are not yet in labor, and especially if this is before or at and around 38 weeks, they will likely consider suggesting an induction to get things going if labor doesn't start on its own. Hypertension and preeclampsia. This is high blood pressure in pregnancy, and this can be a reason that the health of the baby or the birthing parent could be at risk. Diabetes, this could be gestational diabetes or pre-existing diabetes. This can lead to complications like a large baby, which can increase risk during delivery. Fetal growth restrictions. So this is if the baby isn't growing properly, if they are either often referred to as FGR or IUGR, so fetal growth restriction or intrauterine growth restriction, when the baby is not growing properly, so they are measuring small. And there's having too much or too little amniotic fluid, oligohydramnios or polyhydramnios, too much or too little amniotic fluid, and chorioamniotesis, which is there's an infection in the uterus, and this warrants, in some cases, a more urgent delivery. Placental problems. So there's a variety of things that can happen with the placenta, including an abruption or placental insufficiency. So it is no longer viable and helping the baby to grow and thrive in utero. And if there is a stillbirth and the birthing parent needs to birth the baby, this will be initiated with an induction procedure. So non-medical or elective reasons, there is maternal request. So the birthing parent requests to be induced. And this usually is not done prior to 39 weeks, but after 39 weeks, this is something that, somebody could request. And this could be for their own convenience around scheduling. It could be for psychological reasons. They're feeling very stressed or physically uncomfortable, high anxiety, etc. Provider scheduling or logistic issues, and this can be true especially in rural areas, places with fewer hospitals, or with a variety of scheduling logistics that they may have somebody schedule an induction. Or they may, the birthing person may request to schedule an induction so that they are more likely to have their provider present for delivery. And then the history of having a rapid labor. So if somebody has had a previous history of a very fast labor, they may request to have an induction so that they can help ensure the timing or location of the delivery. Now, according to the CDC and the ACOG, which is the American College of Obstetricians and Gynecologists, about 1 in 4 births in the US involves an induction of labor. And elective inductions are not recommended before 39 weeks unless medically necessary. So that is just the statistics around what the guidelines are from these two organizations. Benefits, right? We're going to go through the benefits and the risks. So in a situation where there is a medical reason, when induction is medically necessary, in high-risk pregnancies, there is the possibility to prevent stillbirth. There is a reduction in maternal and fetal complications such as preeclampsia, again, high blood pressure, or gestational diabetes. Lower infection risk when the membranes rupture without labor starting. So, if somebody's bag of water breaks and that bag of water is open for over 24 hours, there's a slight increase of uterine infection, the statistics increasing for uterine infection. And so initiating a induction after a certain point, that doesn't mean that they have to do so right away. But again, after 24 hours, there's a slight increase in that risk. And so that can help to lower the infection risk. And then the timing, being able to control the timing of birth for logistical or safety reasons. This could be due to the distance that somebody is from the hospital, or if they are high risk in their pregnancy. So any conditions that they may have that make them higher risk. And then there are the risks of labor induction, both for baby and for the birthing person. If the estimated due date is not correct, and there is definitely a margin of error with estimated due dates, that could lead potentially to prematurity if the baby is induced before 39 weeks without a medical reason. There is an increased risk of NICU, which is the neonatal intensive care unit, that the baby may need to go to NICU if this is an early term birth. So again, prior to 39 weeks. And then fetal distress, and this is due to strong or too frequent contractions as a result of some of the induction procedures, which we will also be going over. For the birthing person, risks are a failed induction. Sometimes, despite the best efforts, induction doesn't proceed as intended. And in those situations, this would lead to a cesarean birth. There is usually a longer labor for people that are doing an induction. It can take 24 hours or longer just to get the body into labor. So then there's the timeline of labor itself. Excuse me. Increased need for pain relief. So some of these induction procedures, methods, which we'll talk about in just a little bit, namely Pitocin when it is used. This is a synthetic oxytocin. And in this situation, the body is not releasing all of the natural endorphins that help with pain relief. Mm. Mm. So in that situation, people may find a need or desire to use medical pain relief, even if they weren't planning on that previously. Increased interventions. There are a variety of other interventions that can come with the induction process. So again, we'll go over the methods in just a little bit, but there is often increased interventions used when an induction process is used. Infection or bleeding. This is usually associated with a very long labor where somebody may have the bag of waters open for a long time. Um, Uterine rupture, this is quite rare, but it is possible, especially for people that have had a previous cesarean birth or a uterine surgery. So some of the decision factors that go into the provider suggesting to have a induction, gestational age over 35 years of age is recommended to have an induction at 39 weeks. Cervical readiness, which is done through a process called the Bishop score, which I will review. This gives information through a cervical exam about the quality of the cervix, how dilated it is, how thin it is or effaced, and the consistency, whether it's soft, whether it's hard, all of these factors will give them what's called the Bishop score. Maternal and fetal health. So again, if there's specific medical complications or considerations happening, that is likely going to factor into the decision. Preferences and values, right? And this is for the parent themselves, right? If they are wanting to do an elective induction, if they don't have a medical reason, they may prefer to allow labor to proceed and happen spontaneously. And then a history of prior cesarean birth or other complications. Oops. So, one of the tools that we use for gathering information and making decisions is called BRAIN. This is an acronym. And there's actually a whole other parent call devoted to just this topic. So we're not going to get into it very deep in this conversation, but I will just share what BRAIN stands for and direct you to the parent call that is gathering information and making decisions, where we talk a lot more about how to use this and some other tools and techniques to gather information and make decisions. And this also comes from the foundation that it is impossible to know everything. Even if you're taking all of the classes, reading all the books, learning as much as you can, often what people remember in labor is not all of the facts and statistics and left brain information, because the brain is operating in a different way in labor, where it may not hold on to that kind of information in the same way that it usually does. So this is a way that you can, of course, do your research ahead of time. And then in the moment, should you need to make a decision, there is this tool that you can use to navigate as well. B stands for the benefits. So what are the intended outcomes of this procedure? What are you hoping to achieve? What are the risks? This could include what are the steps to the procedure, and also what types of things would be important to know about other procedures associated with the ones that are being suggested. A stands for alternatives, which is there anything else that we could try first, right? Are there any other types of less invasive procedures or suggestions that could achieve the same or similar outcome as the medical induction? I stands for intuition/information. So after asking some of the previous questions, you've gathered a handful of information, and now it's time to do a little bit of a check-in around what do you feel is the best choice for you? What types of things are important to consider for you, and what feels like the best next step? And then N is no, not now. It could be also the framework that we use in Birthing from Within called the next best thing. So it is okay to deny a procedure that's being suggested. And this, of course, should be taken with gathering all of the pertinent information so that you can make a very informed decision for your and your baby's health. But should you come to the conclusion that an induction or anything else is not the way you want to move forward, you do have the medical right to say no. Sometimes that usually will come with signing some consent paperwork. It could also look like not now, right? Maybe you do not want to do this right now. Maybe you're going to try something else, perhaps one of the things suggested in the alternatives, and then come back to this suggestion from your provider. So maybe let's check back in 2 hours, right? That could be what that sounds like. And then the next best thing framework is more of a philosophy around um, not failing at this, right? There's not one right way to give birth. And should whatever you had originally planned or hoped for not be in the cards for whatever reason, that you will do the very next best thing. And sometimes the next best thing is an induction. So you can apply this to anything in the birth journey, anything that's not going as planned or hoped. Um, Coming back to this compassionate reframe of you are doing the next best thing. Now, there are what are often referred to as natural induction methods, so non-medical induction methods that can be used in some situations. We are not going to really tease out like you can use it in this situation, but not that situation because there's too many possibilities, and it is not within my scope of context to make those kinds of diagnoses, but I do like to let people know there's a variety of things that you can do ahead of time in pregnancy to get the body ready for labor. And some of them are very gentle, which, they don't have any adverse consequences. Some of them are a little bit more aggressive and could have some consequences that may be unexpected or unintended. So it is important to have a conversation with your provider and to be fully informed about these methods if you are going to move forward with them. Starting with acupuncture, this is one of the really very least invasive ways. Acupuncture is very gentle. It will not push the body to do anything that your body's not ready to do. It can help to support your body going into labor. Often, as a doula, I'll recommend people after 38 weeks starting with acupuncture. And as they get into the 40th week, starting to do some stronger points, acupuncture points, which their acupuncturist will be able to support them with. Again, will not push the body into labor, but can support the body. This includes acupressure or reflexology, which are different pressure points that can be accessed and pressed on to help support that process as well. Sex or orgasm, as long as the amniotic sac is intact. Again, the amniotic sac is a barrier into the uterus. So if that is broken, there is an increased risk of infection for anything that enters the birth canal. So would not want to, have sex if there was a broken or ruptured sac. But if not, and if it's comfortable or desirable, this is definitely a really effective method to activate the uterus. And one of the things that this does is increase oxytocin, right? So oxytocin is the love hormone, and it is also the hormone that helps to make the uterus contract. So this can be a positive thing for getting the body a step closer towards labor. Walking, just moving the pelvis and walking can help both with gravity, right? Descent, bringing the baby down, helping the baby get lined up in a way that is advantageous for birth, but also helping to create pressure, downward pressure, which can help to increase dilation even and initiate labor getting started, initiating contractions. So in very early labor or up to getting into labor, walking is always a really great thing to do. There are specific kinds of body work, chiropractic methods, massage methods, etc., that can support helping the body be prepared for, aligned, helping to um, soften tight muscles, for example, that may be holding the baby up, and allow more balance in the body overall. Homeopathy and herbs, there's a variety of things that can be used. Again, some herbs are more aggressive and would require a lot of just research to make sure that, you know, if you were doing something to initiate labor more aggressively using herbs, that you have all of the information that you need to make an informed decision. Homeopathy tends to be more gentle with less risk, but it is also something that I would consult with a naturopath or a midwife about. Hypnosis. Some people use different kinds of tracks that they listen to on their own. This is a whole childbirth education method that is used for helping to create a sense of calm or allowing a release of anxiety or imagining or visualizing their baby coming down. And all of these things can have a positive effect just overall on somebody's mental state, emotional state. And the mind body connection is real. So sometimes just helping to tend to any emotions that are happening, if they are, you know, big feelings that you're having about the process, feeling really stressed, feeling anxious. This often increases catecholamines, which are stress hormones, and that decreases oxytocin, which again is the hormone that creates contractions in the uterus. So anything that can help decrease stress and anxiety is beneficial. Evening primrose oil. This is a oil from a plant that is what's called a phytoestrogen, and it also has qualities to help soften and ripen the cervix, which is really some of the first work that the body needs to do before true active labor can really begin, is the cervix first needs to begin softening and ripening and thinning. Castor oil, this is a more aggressive procedure that acts on the bowels. It makes the somebody have loose bowels, and it kind of agitates the bowels, and in that way can help activate the uterus and the contractions. It looks like herbs and homeopathy are on here twice. That's an edit mistake. Sorry about that. Nipple stimulation. There is an increase of oxytocin with nipple stimulation. So sometimes people will use nipple stimulation even in the hospital. I've used that with people as a doula, or they've used it as I've supported them. And that can help to increase contractions. Spicy food, again, can act on the bowels and sometimes can get things going, not always. I've seen, you know, people use a variety. Often when people are doing natural induction methods, they may be doing a variety of these things in tandem. So sometimes it's hard to know, if it was one thing or another, because they're doing several things at once. Maybe there are other things that you've heard about that aren't on this list. So just keep in mind, there's a lot of ideas out there for getting labor going. And this is something, if you are hoping to avoid an induction, especially for post dates, right? If you are coming into the 42nd week, which generally, if it's not a medical induction, you can go to 42 weeks and in the hospital setting. And for most midwives as well, they will recommend doing a hospital induction after 42 weeks. So if somebody is in their 40th or 41st week, there's nothing medically going on that requires an induction, but they are really hoping to avoid one, and they may want to really kind of, start using some of these methods during those weeks leading up to a potential medical induction. So, physical and emotional support for inductions. And of course, as a doula, this is one of the things that I am there for. This is one of the big benefits of having a doula is throughout the labor, whether it's an induction or not, we are able to provide physical and emotional support. But specific to inductions, a couple of the recommendations that I like to let parents know about. Again, this can be a really long procedure. And in the initial part of the induction, when we're waiting for labor to start and the induction process is underway, but somebody may not really have a lot of discomfort or feel very different than they normally do for a good part of that process. And having things to distract you can be really helpful. If you are, know that you're coming into an induction, you may think about bringing some things with you, even like a movie on your laptop or some games, maybe a deck of cards, maybe having a friend bring lunch so that you can just kind of have a little bit of a distraction for some of your time there before you actually get into labor. One of the things that I've experienced is that the waiting process can be very wearing on people mentally and emotionally. And by the time they actually get into labor, where their body is now asking a lot of them, they already feel pretty worn down, either physically or emotionally. And so, trying to find things to help you stay in a positive mindset and to distract yourself can be a really big benefit during that time. Validation and encouragement from anybody is a positive thing. Just reminding you that every step that you're taking is bringing you closer to meeting your baby, giving you encouragement for just every small achievement that you make along the way, really acknowledging and validating all of the effort, the hard work, even if you're not yet feeling contractions, right? That's really important. And reminding you that your body is doing something, even if you're not at the dilation that you want to be after a certain amount of hours, even if, you're not really feeling those strong contractions yet. If the cervix is doing some of the work of thinning, of softening, moving back to forward, all of that is really important and an essential part of this process. Sometimes the focus is so much on the dilation that we forget to celebrate the achievements that are happening along the way before we get to the big dilation phase. So the body is doing a lot of work to get towards this place. And labor has its own clock. There is no right time, amount of time that it takes to get through labor. It is very unique for each person. Some people may even want to like put a sign on the door to limit interruptions or to say that they're hoping to not use pain medication if that's their goal or anything else, right? That just allowing the process to proceed on its own clock. Some of the other things that are helpful are to think about the ambiance in the room. Think about the comfort of the room itself. And that may include even bringing some things from home to the space that you're planning to birth that helps you to feel familiar or comfortable there. Again, oxytocin is the love hormone. It is associated with feelings of well-being. So anytime we feel a sense of safety, of relaxation, comfort, familiarity, that is oxytocin. And so, whatever we can do in this space to create an atmosphere of opening, this might be, having foot massage or hand massage or any kind of touch, snuggling, just feeling like there's some familiar objects or things around when you're looking around. Sometimes people create little affirmations or signs or things that they like to hang up for themselves to read. All of that goes a long way. I really recommend, doing any of those things that sound good or helpful for you. And then again, the next best thing framework. This can be very helpful to reframe disappointment, times of uncertainty, when things aren't going as planned. All right, so we are now going to move into, I'm going to share a different slideshow with you that will talk a little bit and give you some visuals of the procedures, the induction procedures. And we're going to start with the bishop score. So again, this is the method that is used to determine what kind of process or procedure they would use to begin the induction. And this happens with a cervical exam, so an internal exam where the provider is checking the cervix with a gloved hand. They are looking for the dilation or how open the cervix is, the consistency. Is it soft? Is it firm? They are looking for the effacement. This is given in a percentage, and this refers to how thin the cervix is. It is starts out thick and it gets to like as thin as a sheet of notebook paper, very, very thin. This happens over time, so it doesn't happen all at once. Um, Position of the cervix, is the cervix posterior or to the back, or is it anterior, moving towards the front? The cervix moves from the posterior back position to the front position. And then the station of the baby. This has to do with how high or low the baby is in the pelvis. Are they very high up above the pelvic opening, or are they further down in to the brim of the pelvis and actually engaged in the pelvis, right? So there is not a one size fits all for the induction procedures. There are a variety of methods, and the first step is determined by the result of the exam. So this is going to be usually the first step is just seeing what the consistency of the cervix is, the dilation, all of these qualities, and then making a decision about what the first step is. And one thing to know is that inductions is essentially tricking your body into going into labor. And they want to do that in a slow, methodical manner. We don't want to add stress to the baby. And so they are going to likely, use a variety of procedures to get your body into labor. And that means that number one, like we were saying, it can take a while. And it may not just be one tool or one method. There may be a variety of methods. So we're gonna go through the different methods and share a little bit about some of the pros and cons. The membrane sweep, this is least invasive in the induction realm as far as procedures go. And I wouldn't even call it, I'd call it like a soft induction method. This is something that's not usually done in the hospital. It's during an exam at your prenatal appointment. And what they're doing is during an internal exam, they are just loosening the amniotic sac from the uterine wall. So the amniotic sac, which is attached to the uterine wall, as they are doing the exam, they're just kind of sweeping along the edge of the membrane and loosening it from the uterine wall. This is hopefully to encourage labor. And if one of the hopes is that the water may break on its own, not right there in that moment, but maybe within the next couple of days or even a week, this can help to soften the cervix if they are there are what's called prostaglandins that can be released that help to soften the cervix. The other thing is that there aren't medications used in this procedure or drugs to manage it, and it is done in the office, right? Not in the hospital. So if somebody is looking at a more medical induction, say next week or in a few days, they may want to choose to do a membrane sweep to kind of encourage labor on its own and then potentially avoid the other types of methods. Now, the risks are if this accidentally breaks the bag of waters, and the body's not yet ready to go into labor, this could be a premature rupture of membranes where then there's other methods that are needing to be used. This anything going into the vagina can increase the risk of infection. And even though it's a sterile glove, there is that slight risk. This can also be uncomfortable. So, some of the things to consider. Cervidil and Cytotec, these are two different medications that are used for softening and ripening the cervix. So if there's a situation where somebody's cervix is not yet soft or ripe, it's very firm, it's closed, that's what they determine in the Bishop score, then likely the very first step of the induction will be using some sort of prostaglandin medication. There's like I said, a couple different ones. Often it is kind of hospital based which one they may use. They act very similarly to help soften and ripen the cervix. There are options to insert them internally right on the cervix, or to take it like a pill orally. So this is a situation where usually they will have somebody take the pill or do the vaginal insertion, and they may not feel anything for quite a while. In fact, this medication can be repeated several times, usually like every 4 hours over the course of a 24-hour period. Some people may only need one application. Some people may need more because everybody's body is different and is going to respond differently. There will be monitoring. So this is done in the hospital, and they will use the monitors to assess the baby's heart rate and the frequency of contractions. So this is just one thing to consider, that, there is a kind of being a little bit more bound to the bedside with the monitoring. There are also telemetry units, which can allow somebody a greater mobility or even to get into the tub or the shower while they're being monitored. So that's something that you would ask your nurse about if you could have access to. This is, again, a medication that usually what happens is somebody starts feeling a little crampy and uncomfortable. They may use like heat packs to help keep them comfortable getting into the tub if they can get monitors that will go into the tub. That is, usually what somebody's physical experience is. Now, this can actually initiate labor, but for most people, they are going to probably move on to a second step, that this will help to soften and prepare the cervix, but not necessarily guarantee that it's going to put them into labor. But it does help usually get you one step closer. Now, risks, if there are too many contractions due to the medication, it can create stress for the baby. Very rarely that a consequence could be a uterine rupture. If somebody's planning to have a vaginal birth after a cesarean birth, this medication cannot be used. It will increase discomfort. Like I said, requires continuous monitoring. And if it's inserted vaginally, they usually will have somebody laid down for a couple of hours to make sure that medication is dissolving. So that may just be uncomfortable in and of itself. And then the Cytotec, which can be given orally or inserted vaginally, similar risks and benefits. These are similar medications used in very similar ways. So again, it could take somebody doing several rounds of those medications before they get the results that would be needed to move on with the next step. Now, a cervical or a Foley balloon, this is a different method or procedure. And this, for some people, could be the very first step of an induction. If they were to do the exam and they found that the cervix was, thinning and pretty soft and maybe just a little bit dilated, that they were able to insert the Foley balloon, that they may suggest doing this as the very first step. For other people, this may be a second step after doing the prostaglandins. And for some people, they may not do this at all, right? They may go straight to Pitocin, which we'll talk about next, and avoid doing the Foley or cervical balloon. So what you're seeing in this image, there's like a little tube called a catheter. It's not a bladder catheter, but it is inserted into the vagina and through the cervix, and it has a little balloon on the end of it. And after it's inserted, it's deflated when it's inserted, and then it gets inflated after they insert it with sterile water. It's inflated with sterile water. They push sterile water through the tube into the balloon, and it blows the balloon up just a little bit. And this is called mechanical dilation because it is mimicking the pressure of the baby's head resting against the cervix. And that act alone helps to dilate the cervix. Just like when the baby comes down and begins to apply pressure onto the cervix, it helps the cervix to dilate. So this is mechanically opening the cervix by mimicking the pressure of the baby's head onto the cervix. Usually what happens is somewhere around 3 or 4 centimeters, the balloon falls out on its own, and that's how you know it worked. So there are some providers that will do this in the office, and you don't need to actually go to the hospital until the balloon falls out, and then you would make your way to the hospital. Other providers or hospitals will have you come into the hospital, and then once you're there, you would stay for the remainder of the time until you give birth. So one of the benefits that I haven't mentioned yet, this can be removed if needed, if there was a reason that it was very uncomfortable, that it could be removed. And again, could be if it's done in the office, be able to return home after placement until the Foley falls out. Again, anything inserted can increase the risk of infection, so there is that slight risk. Accidentally breaking the bag of waters. This can be quite uncomfortable for some people to have the Foley placed. So that is, just one thing to consider. Often as a doula, when I'm supporting somebody doing this procedure, I will offer breathing, relaxation, comfort techniques as this is happening so that they can kind of relax and soften through the procedure. Anything that kind of agitates the cervix can create a little bit of bleeding. So that is something that, somebody may see in this procedure. And then we have Pitocin. Pitocin is synthetic oxytocin. It is administered through an IV. So to receive Pitocin, one would need to have an IV placed first. And this is going to mimic the oxytocin. So, Pitocin is very good usually at doing its job, which is to make the uterus contract. It usually is the tool that's used to actually get labor started, to get the contractions strong enough, long enough, close together enough that somebody can do the work of really actively opening the cervix. Um, Again, this could be a first step for some people if their exam shows that their cervix is already soft and ripe and quite dilated, then they may just begin with Pitocin. They may do this step, and often it is the step after the prostaglandins or the Foley balloon. So it could be, a third step, a second step, a first step, depending on what's going on. This is also used to augment labor, which we haven't yet talked about, but augmenting labor is when labor has started on its own, but for some reason has slowed down or stopped to the point where contractions are not happening at a strength or a rate that will really actively help to open the cervix or bring the baby down. So, if, for instance, usually a variety of other things may be tried first, like being upright and using positions and gravity and movement. And in that situation, if for some reason over a period of time that doesn't work, they may usually recommend Pitocin. Now, if somebody has an epidural and labor slows down or stops, they may not be able to use all of the movement and mobility and upright positions as much as if they didn't have an epidural, because once somebody has an epidural, they will be in the bed. But there are still positions and things that one can do in the bed to increase gravity and upright positioning. But often Pitocin is used in a labor with an epidural that has slowed down or stopped. The contractions have slowed down or stopped. So this is quite common. And as I was mentioning, this experience for the birthing person is often that the Pitocin contractions are more intense, they're more painful. And again, this is because with Pitocin, this is not crossing the blood-brain barrier. Oxytocin is produced in the brain and released through the bloodstream. There are receptors on the uterus that oxytocin goes down and kind of fills and does the work of contracting the uterus. And in tandem, the endorphins are also being released, which are the body's pain relievers, right? So when there's a synthetic version of oxytocin or Pitocin used, we are not getting all of those good endorphins that the body will be able to help to comfort the birthing person in that pain as much. So this means that there is often an increased need or desire to use medical pain relief when somebody is using Pitocin. But I also like to say, I have had many experiences working as a doula for people that were using Pitocin and didn't use an epidural, and they were able to manage the intensity of their labor and avoid medical pain relief if that was their goal. So, Pitocin, like I said, the benefits are that they do usually work. It's at creating stronger, longer, more regular contractions. The Pitocin can also help prevent hemorrhage. This is usually a situation, especially postpartum, where right after the baby's born, they will use Pitocin in many situations currently in the hospital to administer Pitocin to help prevent hemorrhage, just more of a preemptive measure. And in situations where the labor stalls or stops and all of the other things that somebody may do to try to get things going again aren't working, Pitocin can help somebody avoid a cesarean because it can get the contractions going again and help the baby to be born vaginally. Some of the risks, Pitocin, if they are having too many contractions, too strong of contractions, this is overstimulating for the uterus. It can also create stress for the baby. The experience of euphoria and having all of the um, natural pain relievers aren't going to be there. It is associated with higher instances of newborn jaundice and lower APGAR scores, which um, are the just first assessments of the baby's tone and um, viability as far as their color, their heart rate, they're visibly pinking up, right? That they're getting the air that they need and that their lungs are working, all of these kinds of things in the first and fifth minute after they're being there's an assessment of all of these things called the APGAR scores. So it doesn't necessarily mean that the baby is, not doing well, just that they may score lower. Higher admission to NICU and potentially delay milk supply and can cause you to retain water. So, along with the Pitocin is given IV fluids, and depending on how long somebody receives Pitocin over time, having an increased amount of fluids through the IV can create edema or the retention of water. Um, the other things that aren't listed here are that Pitocin can be turned up or down and has a pretty fast effect when done so. So if there is, an, too many contractions happening or the baby's heart rate is too high, the Pitocin can be turned down or even off, and it moves out of the body rather quickly. So that is, I would say, is one of the benefits of it is that it can, be titrated over time in a way that um, is more tailored to the person's needs and however it's affecting their body. And then breaking the bag of water. This, again, artificial rupture of membranes or AROM. This is done with an amnio hook, a little tool that you can see here. It looks kind of like a crochet hook. It is used to, during an exam, open the bag of waters and release the amniotic fluid. The hope in this is that the release of the fluid, number one, can provide a lot of good prostaglandins to help soften and prepare the cervix and get things going. But also, the baby can move down onto the cervix, applying hopefully an even pressure, which will help the cervix to open and dilate. Now, one of the things to note is that after the water breaks, and this is true whether it is a procedure done by your provider or if it is happening on its own, wanting to limit anything inserted into the vagina, again, can introduce bacteria into the uterus. And this includes limiting vaginal exams. So, unless there's a medical reason, not, doing exams just for curiosity. There will be regular temperature checks because a fever is one of the first indications of a uterine infection. And they will likely keep the monitors on. One thing I didn't mention in the Pitocin also is that they will do continuous monitoring while Pitocin is being administered. They want to be checking for the baby's heart rate, how many contractions are happening. And at least for a period of time following the water breaking, they will want to do the same thing to just make sure that the baby's moving and that their heart rate's good. And they will also, be able to check the fluid to see that it's clear. If it's not clear, that often means that the baby has had their first bowel movement called meconium, which is quite common and not necessarily um, problematic in and of itself, but it's just something they'll note and want to look out for. And some of the benefits of breaking the water, this can speed up or start labor. This is especially true in a situation where labor is already, in a little bit more of an active state where the cervix is dilated already to at least 4 to 5 centimeters. Contractions are happening a little bit regularly. And that's for a first time vaginal birth. For somebody that's given birth before, breaking the water sometimes is suggested as the very first step, or maybe even the only step of an induction, because often people that have birthed before, labor is shorter. So the thing to consider here is that if the water is broken and it does not get labor going, this does create more of a timeline for birth because of that infection risk. So, we don't want to break the water purposefully too early. We really want to make sure that the baby is low enough, also that there can't be cord compression or prolapse where the cord comes out. That the baby's in a good alignment. So the provider will be checking for, the positioning of the baby and for how the baby's aligned, to assess whether this will be something that is safe. Um, Once the fluid is removed, the body will continue to make fluid, but a good amount of it will be released. And so, if the baby's not low down enough in the pelvis, this could create a situation where there's not enough fluid for them to really have good mobility to get into a better position. So this is just, again, something that the provider will check to make sure the baby is low down enough in the pelvis, to make sure that there's not a risk of cord prolapse or compression. Now, there's no guarantee, for any of those things. They do their best to assess the safety. And in some cases, uh, some of these things could happen. And then vasa previa, which is the loss of blood by either the birthing person or the baby. That is a more rare thing that can happen. So this is just a very brief but hopefully comprehensive overview of what some of the induction procedures, some of the things to consider in making these choices. It is not something to take lightly, as there are risks to anything that you do to um, initiate labor. And one of the things to remember is that this is a process, it's not a single event. So, really mentally and emotionally knowing that it could take time and setting yourself up to support yourself emotionally, mentally, physically, knowing that you still have choices. And I think this is really important for parents that are really hoping to avoid any interventions. And then there's something medically that happens where the induction is being suggested, and it seems very clear that this is probably the safest thing to do to get their baby out sooner than later. This can obviously feel very disappointing and sometimes feel like all of the things that they wanted are no longer available to them. And so I do always like to remind parents that you still have choices. Just because there is an induction happening doesn't mean that all of the things you were hoping for can't happen. In fact, sometimes some of the induction processes can be started, like for instance, Pitocin, and as the body gets into labor, we could even turn the Pitocin off, right? We were talking about how it can be turned off. And oftentimes, once the body's in a rhythm of labor and the cervix is open at least 5 centimeters, that rhythm will continue even if we turn the Pitocin off. So somebody could resume then going forward without using medication at a certain point in labor. And it is still possible, if it is one's goal, to avoid medical pain relief, to do so. And inner preparation matters, right? At Birthing from Within, one of the things that we really focus on is the from within piece, right? Yes, information is important, and having informed, evidence-based information, consent, all of these things are very important. And really taking inventory of your own concerns, worries, fears, questions, what you might do to prepare yourself emotionally, psychologically for meeting any possible thing that might arise in labor, right? And knowing that, again, there's not one right way to do this. There's not one right way that it looks, and you can't ever fail at birth, right? So, thank you so much for joining me here today. Again, like I said, this is part of our parent membership, and included in that membership are monthly calls that are recorded and added to the call library. These are free for parent members, and the next one coming up October 6th is going to be focused on prenatal nutrition. And in November, we have baby proofing your relationship, things that you can do to prepare ahead of time for bringing a baby into your relationship life. We also have classes for parents that are both offered as a 90-minute intro and then a 4-week series. So coming up in December, we have an intro to preparing for postpartum, which is free for parent members. And this is going to be focused on all sorts of things that you can do to prepare for this big time in your life and this transformational change in your life. And then in January is a 4-week series where we dive much deeper into this topic. And this is a 20% discount for parent members to take the 4-week series. But again, the intro is free. So if you are here today and you are not yet a parent member, this is something that will offer you these continuing education calls every month, interactive workshops, a whole digital resource hub with documents and downloads, etc., discounts on courses and events, and tools designed to support your growth through pregnancy, birth, and beyond. So thank you so much for being here with us. We really do appreciate it and look forward to seeing you again soon.